Erectile dysfunction is the inability for a patient to get an erection for any period of time. We can have intermittent erectile dysfunction where you have issues from time to time that is not persistent, but typically we look at it for guys that have persistence of that erectile dysfunction or inability to get an erection for longer than 3 to 6 months. It's hard to know the exact prevalence of erectile dysfunction just because a lot of guys do not talk about it, but the studies that are out there with large group populations says somewhere around 40% of guys have some level of erectile dysfunction between the age of 40 and 70. So that's pretty common if you think about it. It's probably a little bit higher than that just from what I said before where guys don't really report it. But remember that erectile dysfunction is a range. It can be as little as not being able to keep an erection for the entirety of a sexual experience or not being able to get an erection at all from the get-go. So it is a range and there are different treatment options that may fit different ranges of erectile dysfunction. ED has a large range of causes. It starts with usually arterial insufficiency, which means that you don't have enough blood flow to get into your penis to get an erection. That's one of the most common causes. You can also have something called venous leak, where you're able to get an erection, but the erection doesn't stay around very long. There can be a combination of both of those. So you can have both an inflow and an outflow problem that contributes to not getting an erection as hard as you want to and not being able to keep that erection as long. Another cause can be a neuropathic erectile dysfunction, meaning the nerves that go to the penis to create an erection aren't functioning as well. That can be caused by diabetes, heart disease, and spinal cord injuries, which are common causes that we see. For the majority of guys that come into my clinic with erectile dysfunction, it's some level of cardiovascular disease or vessel disease that's leading to inflow and outflow problems for their blood flow. In general, ED is a exam and history-based diagnosis. Often guys will have stories from the last 3 months to 3 years to 3 decades where they haven't been able to get erections. And just talking through their experiences during sex and sexual encounters, you can kind of glean what the cause and the workup for the erectile dysfunction is. If there's any question or as a patient we have a discussion and you want to get more workup, there is the ability to do what's called a penile Doppler, where I would give you an erection in the clinic and measure the blood flow in and out of your penis with an ultrasound machine at the same time. While that can give some information, it doesn't usually change the treatment plan, and so I don't do that on every patient unless we have a discussion about it. For the majority of patients, it's a history-based diagnosis, and so after our conversation and exam, we can kind of get into the treatment options. There is some level of erectile dysfunction that has a preventative aspect. Cardiovascular disease is a main cause of erectile dysfunction, and so living a healthier lifestyle throughout your life, exercise, diet, overall substance use, can prevent your progression to erectile dysfunction. However, even with all of those things, there's a large amount of the population that still has erectile dysfunction as they get into their 50s, 60s, and 70s. Some of it is genetic. You're going to have some problems with cardiovascular function, and so that's a little bit unavoidable. It's not usually something that patients do to themselves. It's just a combination of age, genetics, and some level of lifestyle. So while you probably can prolong it, if it's going to happen to you, it's probably going to happen to you at some point. There is a wide arsenal of treatments that we have at our disposal to help with erectile dysfunction. As a urologist with fellowship training, I have access to all of the treatments that have been FDA approved and studied through the urologic world. And so while your primary care doctor is someone who's good to go talk to initially about erectile dysfunction, they may be able to start you on some medications. A urologic specialist is going to be able to offer you medications, injections, penile implants, where some patients may not want to wait long to get to the end goal of a penile implant, which we are able to offer. Now, that's a discussion that we would have to have, and that is not right for everyone, but there's the ability to talk through all the options so that you know what is available to you from the get-go and may alter your decision making. My approach is very fraternalistic. I want you to come in with your goals in mind. I can give you the options that we have and give you the risks and benefits of those. For some patients, there may be things that are not an option, and that would depend on your history and what you've tried and what your goals and preferences are. But I don't push anything on you. My idea behind it is I want to lay everything out on the table, give you the risks and benefits. I will give you my opinion on what might work best in your situation. But at the end of the day, at the end of the visit, I want you to make a decision that you're comfortable with and that you're going to be happy with going forward. The satisfaction rates for all of the erectile dysfunction treatments vary from patient to patient. In general, medications work for a large amount of the erectile dysfunction population for a short period of time, but oftentimes, depending on whether the cardiovascular disease progresses or just as the medications wear off, they aren't as successful over time. Similar for injections, the satisfaction rates typically are very high for guys that use them, but diminishes over time as the efficacy of those treatments diminishes. The implant that we do, the penile implant, which is a surgical procedure, has a 95% and higher satisfaction rate. So for patients that elect to do that and make that decision, which is a shared decision with me, their satisfaction rate is relatively high and persists for a long period of time. The long-term consequences of not having erections is a little bit complex. It doesn't really follow the old adage of use it or lose it. However, there have been some studies specifically in patients that have had prostatectomies or their prostates removed, where the longer they wait after that procedure to have treatment, they actually have some shortening of their penis as they don't use their erections. So there may be some element of shortening as you don't use your erections going forward. But overall, there's not anything long-term that's going to hurt your overall health. This is really a quality of life improving phenomenon with the procedures, with the medications. And so while if you're going to get treatment, coming in to get it earlier is probably better so that you don't potentially lose length, there's nothing that systemically is going to happen where you're going to have diminished health over time if you don't use your erections.